Welcome, everybody, to today's acid-base conference. I'm going to continue with the theme of metabolic alkalosis and show you some new parameters today that we didn't discuss last time. So again, these are all the hypothesized factors that you'll hear about clinically that can be associated with a metabolic alkalosis. There's many of them, and we covered some of these last 2 weeks. We'll cover some more today. So again, remember that whenever you think of a metabolic alkalosis, your brain must immediately think of the three phases that have to be answered clinically. The first is the generation phase. In other words, you're asking, where did the bicarbonate come from? And in general, you're thinking of a vein, unless the patient was given bicarbonate exogenally. Even then it's a vein if the MD did it. But you're in general thinking of what vein is putting bicarbonate into the IVC. It's either the gastric vein or it's the veins coming out of the colon, and it could be the kidney, such as in Bartter syndrome or Gittleman syndrome. But there has to be some vein pumping bicarbonate into the body. That's the generation phase. And then the next phase is the maintenance phase. And there you're asking, well, I have a source. I have a vein pumping bicarbonate into the body, but why isn't the kidney getting rid of it? As I've showed in previous weeks, the kidney easily gets rid of bicarbonate because it's absorbing it at a maximum amount normally when the blood bicarbonate's around 24. So anything above that, the kidney just dumps. It doesn't typically reclaim that bicarbonate. It is inappropriately reclaiming the extra bicarbonate coming through our glomeruli in metabolic alkalosis. And you have to ask yourself, why is it doing that? So the maintenance phase really refers to the kidney. The physiology of the kidney has been altered such that it's not capable of dumping the bicarbonate load that's coming from the generation phase. And that's what you have to try to think of in the maintenance phase. And then the last phase is the so-called correction phase, where you basically have a reversibility of the maintenance phase. Something has occurred that turned the kidney's excess reclamation of bicarbonate off, such that the bicarbonate in the blood now returns to its normal level. So and they're not exactly a mirror image. It really depends on the underlying causes, but there's these three different phases of metabolic alkalosis that you've got to think of in every patient, and you might be in a different phase. These are temporally associated with each other. They're not necessarily simultaneous. So we reviewed potassium in a previous talk. Potassium, if you ask an attending, they might tell you, well, hypokalemia can cause a metabolic alkalosis, or sometimes they'll be a little more precise and say potassium depletion, which doesn't necessarily refer to the blood concentration. That's sort of a whole body input-output concept, that the body has less potassium in it somewhere. At any rate, as we showed over the past few weeks, in humans, when you invoke dietary potassium depletion, when you're on a normal sodium chloride intake, the bicarbonate hardly changes. So as long as you're on a normal salt diet, just decreasing potassium in your diet changes the bicarbonate very little. That's the important teaching point. However, if you're on a low salt diet, then the effect of potassium deprivation in the diet has a much greater effect, and the metabolic alkalosis is much higher. So the question then becomes, where did the bicarbonate come from? Is it the gastric vein? No, clearly not. You're not vomiting. Is it the colon? No, you don't have any colonic diarrhea. Is it the kidney? It turns out it's not the kidney. I won't go over that data again. It's not the kidney generating it. Well, there is another source of bicarbonate, and that is a transcellular shift, which people don't think about at all clinically. And you have to start thinking about that, because the bicarbonate could actually be coming from the cells, not directly, but through this mechanism shown here. So if there's transport systems that exchange a proton for potassium across the cell membrane. This may not be the same protein. It could be a proton channel or potassium channel. There are in red cells potassium hydrogen exchangers. It's one protein. You remember in the stomach, there's a KH exchange pump that splits ATP. So there are KH exchange processes. We won't go into all of them today, but the bottom line conceptually is that if you lower the extracellular K by whatever mechanism, potassium will leave the cell down its concentration gradient, and sometimes it'll be in exchange for a proton. Now, it doesn't have to be. It could be in exchange for sodium, or you could have potassium chloride leaving the cell. But depending on the situation and the other electrolyte abnormalities and the acid-base status, you can get KH exchange. And when you get that, you have a proton going into the cell, but what that does is it generates one bicarbonate ion in the extracellular fluid. So for every proton going in, you now have one more bicarbonate ion. And so it turns out in the metabolic alkalosis of just pure K deprivation, at least in the dietary K deprivation, the metabolic alkalosis that you get when you're on a low salt diet is essentially from a transcellular shift. It's not a whole body addition of bicarbonate. The amount of bicarbonate in the body is identical. It's just shifted from the cells to the outside. The H going in depletes the cell of bicarbonate, and the outside gets a bicarbonate generated. The sum total of bicarbonate in the whole body has not changed. But when we say metabolic alkalosis, we're not talking about total body bicarbonate content. All you're saying is that the concentration of bicarbonate increased in the blood vessels and presumably also in the extracellular fluid. So the mechanism here is an interesting one that you never hear about clinically, but you should remember it from now on, that you can get this KH exchange mechanism. And when that occurs, you actually generate a bicarbonate ion outside. The other causes of metabolic alkalosis, due to gastric vein addition or veins coming out of the colon or the renal vein, do add bicarbonate to the body. We also talked about mineralocorticoids. It's a similar idea. If you just give DOCA or aldosterone, you change the bicarbonate very little. This effect varies with the potassium deprivation. So it's sort of like potassium that varies with sodium chloride. The mineralocorticoid effect varies with how much your potassium depleted. So patients who have an adrenal adenoma or Cushing syndrome or anything where you have, I mean, even with Cushing syndrome, you have metabolic alkalosis because at high enough cortisol levels, it acts on the mineralocorticoid receptor in the kidney, as we talked about months ago. But at any rate, any of the causes, no matter what they are, if you have more hypokalemia as reflective of K depletion, you will get, for a given level of mineralocorticoid, a higher bicarbonate concentration. But you can see patients who have Little syndrome or an adrenal adenoma, and the K is not that low and their bicarbonates are not high. You don't have to have a metabolic alkalosis. So remember, it's not a fixed number. It really varies between patients. But one of the prime drivers is whatever the potassium is. And the concept is clinically, if the potassium in the blood is lower, for a given mineralocorticoid level, you're going to get a higher blood bicarbonate. So always remember that. And the magnitude is less when you have decreased sodium chloride intake. So the exact opposite of the hypokalemic induced metabolic alkalosis, where that effect is greater the lower the sodium chloride intake. Here, if you decrease the sodium intake, you actually shut off the effect on the blood bicarbonate. So just some things to memorize. You couldn't predict these things. Okay, so getting back to our factors, what I'm going to talk about now, we're going to focus on chloride. Now, chloride has come under a number of different sort of categories. One is the chloride concentration in the blood, which is not shown here. Another is chloride depletion, which again means whole body loss of chloride. It's the content of chloride in the body. And some people talk about the chloride concentration in the lumen of the collecting duct, and that actually will become probably the most important effect of chloride that we'll talk about in subsequent weeks. But so let's just focus on chloride now. So we finished with potassium and aldo, and now what's the story with chloride? Well, Schwartz and his colleagues in the 1960s did a series of studies examining the role of chloride in metabolic alkalosis that I'll show you now. So this was a study from 1962 in the JCI, where in the papers entitled Factors Governing the Correction of the Alkalosis Associated with Potassium Deficiency, the Critical Role of Chloride in the Correction Process. And what they did is, this was in dogs, they gave the dog deoxycorticosteroids, a mineralocorticoid, with sodium bicarbonate to create the metabolic alkalosis. So here, if you look at the bicarbonate, when they gave the deoxycorticosterone and bicarbonate, you can see the blood bicarbonate increased and reached a level of about 35. And then what they did was they either gave back potassium bicarbonate, sodium chloride, KCl, or they gave chloride in exchange for phosphate. So it was an anion swap. These are, a cation with an anion. So there's many different ways to give chloride, and they did it either with a cation or swapping it for phosphate, decreasing the phosphate in the diet. And so this slide shows the effect of sodium chloride. So prior to that, they give K bicarb. So let's go again. They gave sodium bicarbonate with the mineralocorticoid, got the bicarbonate up to 35, and then they waited a little bit longer to get a steady state, and then gave potassium bicarbonate, and nothing much happened. The bicarbonate dropped a little bit, but basically it stayed elevated. But when they gave sodium chloride, the bicarbonate went back down to its original level. So you don't know, is it the sodium or the chloride? One of them did something. So then in this group, they gave potassium chloride, same experiment. They raised the bicarbonate, gave K bicarb back, and here they gave potassium chloride, and it did the same thing. And then in this last group here, this was the chloride phosphate swap. So they didn't give sodium and they didn't give potassium. They just gave chloride and decreased the phosphate, and again, the bicarbonate recovered. So the only constant thing here really is the chloride. It didn't seem, especially in this last group, there was no sodium or potassium given altogether, and yet the bicarbonate recovered. They did a subsequent study a few years later in 1965 in humans, and same sort of thing. They except that the metabolic alkalosis was created by giving sodium nitrate. If you give sodium nitrate IV to a human, the bicarb, you can create a metabolic alkalosis. We won't get into why that is now, but that's a fact. So bicarb was here. They gave the sodium bicarbonate, they gave the, well, yes, they gave actually sodium bicarbonate here. I think they had given sodium nitrate. I'm not sure exactly when they gave the nitrate here, but at any rate, they created the metabolic alkalosis. And then they gave sodium chloride back, and you could see how it recovered here. So again, sodium with chloride, you don't know which of the two had the effect. K bicarb, again, did very little. And then here they gave KCl, and the bicarbonate recovered. And here they did their chloride phosphate swap, and it recovered. So very similar to the dog studies. Now, what they noticed, and this is just showing the KCl effect again without sodium, that during the and this shows the sodium nitrate. I guess they did it both ways. They either gave sodium nitrate to create it, or they gave sodium bicarbonate. But at any rate, what you see here is during the creation of the metabolic alkalosis, there was a decrease in the chloride excretion in the urine and the K excretion in the urine, actually a decrease in balance. So the chloride excretion in the urine went high and the K excretion went high. They went into negative chloride and K balance. During this period, the kidney started dumping chloride and potassium. And then when they gave the KCl back, the body went back into balance. This is actually cumulative balance. It's not just the urine, it's intake minus output. Excuse me. So you can see the body went into negative chloride balance, but it's because the kidney was dumping chloride, and into negative potassium balance because the kidney was dumping potassium during this phase. Not clear why it was. We can probably understand this now a little better with modern understanding. I won't get into that, but just empirically, when the metabolic alkalosis was created, the kidney excreted excessive potassium chloride, and only when KCl was given back, the K balance went back to normal, as did the chloride balance, because the intake went up. But not shown here is the same thing occurred when they gave sodium chloride. So The K balance was corrected when they gave K, but the K balance was also corrected when they gave sodium chloride. So confusing. But again, it didn't seem to matter whether they gave K or sodium. And what they didn't explain was why the kidney went into negative potassium chloride balance during this phase here. So the results show that KCl or sodium chloride could correct the acid-base disorder, including both the potassium chloride deficits that occurred in their protocol. And there was no correction of the acid-base disorder when they gave K bicarb. They also gave K phosphate. So it seemed like it had to be chloride. So they interpreted this to suggest that chloride is the responsible ion here, not the K, not the sodium, but the mechanism was unclear. However, since sodium chloride and KCl both corrected the K and the chloride deficits, they didn't rule out an effective K per se, even though it looked like because sodium chloride could correct it also, K wasn't important in the correction. So it was still confusing. Then a subsequent paper was done looking at the response to selective hydrochloric acid removal. So what they did was they aspirated the stomach to create a metabolic alkalosis similar to vomiting. And they gave back the sodium, potassium, and water losses that they could measure from the stomach loss. So it wasn't that they were removing sodium, potassium, or water from the stomach. They replaced all that. But they still, even though they replaced the sodium and potassium from the NG suction that they were removing and the water loss, they still created a metabolic alkalosis. And what happened was they still got, like the other ones, chloride loss in the urine and potassium loss in the urine. So even though they replaced the sodium and potassium loss from the NG tube, the kidney was still dumping potassium and chloride during this phase. A totally different type of metabolic alkalosis. This is now due to NG suction, not sodium nitrate. So it seemed that in all these types of metabolic alkalosis that were created, there's this common dumping of chloride and potassium in the urine, such that you go into negative chloride and potassium balance. So they found a minimal change in sodium balance. It's not shown here. It was just potassium and chloride were dumped in the urine. Sodium balance was about the same. And the loss of K in the urine accounted for the potassium balance negativity. And potassium chloride, not shown here, corrected both of these. So when they gave KCl, the chloride balance went back to normal, and the potassium balance too, as you might expect. If you're matching the excess urine output, you're going to bring the balance back to zero. So they interpreted this to suggest that chloride was responsible, but again, the chloride and K were not distinguished. So another paper was done in '66 looking at the effect of this without repairing the potassium. That was the idea. So what was done was to aspirate the stomach again, create a metabolic alkalosis. Here you can see the bicarbs 36 by NG cut, but due to NG suction. And then what they did is they corrected the metabolic alkalosis with sodium chloride. And you can see giving sodium chloride, the bicarb corrected, but the potassium deficit still was present. So again, during the metabolic alkalosis, the kidneys dumping potassium and chloride, same as before. When they gave sodium chloride, they correct the chloride deficit, right? They're now giving excess chloride. So now the body's cumulative sodium chloride loss comes back to, actually it went positive. They gave more chloride in during this phase as sodium chloride than the kidney had lost. So patients were actually retaining chloride up to 500 milliequivalents by the end of this number of days. But the potassium deficit was still occurring. They didn't correct that. So what they interpreted this to mean is that the chloride is what is responsible here, not the potassium, because they could correct the metabolic alkalosis just with sodium chloride, even though they still had potassium depletion in the body. However, this study was criticized because it was felt they gave too much chloride, and they actually didn't go back to neutrality, but they actually went above normal, and maybe chloride expanded the body, or maybe they caused volume expansion, and the volume expansion was associated with correction of the metabolic alkalosis. So again, it wasn't perfectly clear study. And the term volume and ECF volume expansion really needs more precision when you use it clinically. What does the term, and we've referred to this previously, what does the term contraction alkalosis mean? Does it simply mean volume depletion and therefore you have a role in the maintenance phase? Does contraction alkalosis refer to a loss of water around a fixed amount of bicarbonate? Does it refer to the drop in the GFR? What's the role of volume depletion in a low GFR? And conversely, what's the role of volume expansion? Does it mean the GFR has increased? Does it change the filtered load? All these things cannot be thought of in isolation clinically because they all occur together, and yet any one of them could be causally related to what we're seeing. So it's very, very complicated. So people tried to, years ago, to isolate all these different factors more precisely. So here was a paper, again in the mid-60s, called Contraction, in quotes, Alkalosis After Diuresis of Edematous Patients with Ethacrynic Acid. So they took edematous patients, gave them ethacrynic acid, and generated a metabolic alkalosis. You can see in this middle panel here, the bicarbonate went up to about 32 or 3. pH went up as you'd expect. The PCO2 went up because of the ventilatory compensation. The chloride went down, and the K went down, as you'd expect in patients with ethacrynic acid. And so the thinking was that the bicarbonate went up due to a loss of water from the diuretic around a fixed amount of bicarbonate. But as I talked about last week and before that, this concept now is not felt to be what's going on, that just losing water around the same amount of bicarbonate, a pure example would be diabetes insipidus, doesn't raise your blood bicarbonate level. And I referred to this previously, this very nice review, if you want to read it in KI from years ago, called Dilution, Acidosis, and Contraction Alkalosis, Review of a Concept. So currently, these things are not thought to be a factor clinically, either because of the loss of water is not great enough, but more importantly is what's shown here. There are non-bicarbonate buffers that keep the bicarbonate from changing. So remember this equilibrium, we tend to show only this reaction where carbon dioxide and water makes carbonic acid, which breaks up into bicarbonate and a proton. But this is also in equilibrium with other buffers, all the other buffers, protonated albumin, hemoglobin, phosphate, all the other buffers shown here as a B. They're all showed as one entity, even though it's obviously not true. But these are protonated or deprotonated, and they're in equilibrium with the bicarbonate buffer system. So if you, for instance, decrease water in a beaker and have it open to air, or your patient and their ventilation is normal, you're momentarily going to increase the bicarbonate, proton concentration, carbonic acid concentration. On the left side here, if you have an open system as opposed to a closed system, the carbon dioxide concentration will not go up because it's either open to air or you have a lung that's going to keep it at its original level, and that's going to cause a shift in the equilibrium of this reaction towards the left, from the right to the left. But what that does is it causes these other buffers to deprotonate, and what's going to happen is you're going to consume bicarbonate. And so if you have other buffers in the system and you do this, the bicarbonate concentration will change in proportion to how much buffers you have at that pK. The more you have, the less the bicarbonate changes. If you have no other buffers, then the bicarbonate will go up to some extent. It will go up less than it would if this was a closed system. But because our body is an open system and because we have other buffers, just raising the concentration of these things will not, in the steady state, keep them elevated because of these factors. The reaction is driven to the left because the carbon dioxide is kept at 40 in our bodies. And this deprotonation of all the buffers drops the bicarbonate, and the effect will be greater the more of this protonated buffer you have. You can just dial in the amount you want and get a different amount of bicarbonate decreased to its normal original level. So because of that, contraction alkalosis is not felt to be a clinical cause of an elevation of the bicarbonate, and therefore you should never use the word contraction alkalosis. Okay, so here's another paper where they tried to look at the chloride in more detail and volume expansion. They corrected the metabolic alkalosis with what they called isometric expansion of fluid. This was in dogs. They gave them ethacrynic acid and a chloride deficient diet, and they gave 3 types of IVs. One was an isometric chloride infusion. So remember, when the metabolic alkalosis is created, the chloride is less, the bicarb's higher, but the chloride's less. So they gave an IV with the lower chloride. They wanted to keep the chloride concentration of whatever it was during metabolic alkalosis and not what it would be in saline. And then they also gave a low chloride infusion, which matched the metabolic alkalosis. The isometric was just what it would be in normal blood. So that was higher than the low chloride infusion. And then they also gave the isometric with deoxycorticosterone. But the bottom line is they found that the correction was the same in all 3. It didn't matter whether DOCA was given. It didn't matter what the chloride concentration was in the IV. It seemed to have the same effect. It was corrected similarly. So it was concluded that the change in the blood chloride, so the chloride concentration in the blood cannot be a factor in the correction, and by inference, they were thinking also of the generation. It's not the chloride concentration in the blood that is doing this. And then during volume expansion, which they were sort of focusing on, of course, they were doing many other things too, but volume expanding with each of these things, this is a hypothesis, there's no data. They hypothesized decreased proximal tubule transport of chloride, shifting it to the distal nephron, and somehow chloride in the distal part of the nephron was doing the work in correcting the bicarbonate. And that actually was very prescient because that's, in a certain sense, how we think about it now with Pendrin in the collecting duct. And this was 1968 when this thought first appeared in print, that somehow chloride getting to the distal part of the nephron is what is doing it. They also wanted to rule out an effective GFR. So this is another paper a few years later where they selectively, the title is Selective Chloride Retention in Repair of Metabolic Alkalosis Without Increasing the Filtered Load. So what they tried to do here, in the previous paper, they gave those solutions and the GFR increased. So here they tried to keep the GFR constant by they had an aortic clamp on the animal while they were giving these 3 types of solutions. And so the aortic clamp kept the GFR despite these IV solutions at what it was previously. They were able to keep the GFR constant and preventing it from going up. And they still found the same thing, that even though the GFR was kept at a lower level and not allowed to increase, it didn't seem to make a difference. So what they hypothesized was that independent of the GFR, independent of the blood chloride concentration, somehow giving these solutions sent chloride to the distal nephron and modulated chloride bicarbonate or some transport of bicarbonate in the distal nephron to dump the bicarbonate. So I want to focus, because of that, and also just as a thought experiment, the role of GFR per se, and we'll conclude showing you Marty Kogan's studies that were done looking at GFR and metabolic alkalosis. Because as I always say, if you give a bicarbonate load to someone with CKD5 and the same bicarbonate load to someone with normal renal function or a lower CKD stage, the patients with the worst CKD are going to have a higher rise in their bicarbonate for the same load, because the kidney cannot dump the bicarbonate as easily. It depends on how much bicarbonate is coming through per unit time through all our glomeruli. That's called the filtered load of bicarbonate. So let's just take this thought experiment. The normal filtered load of bicarbonate is 25 milliequivalents per liter. That's the blood bicarbonate concentration. GFR, let's say, is 144 liters a day. So you multiply these 2 together to answer the question, how much bicarbonate is coming through all our glomeruli? That's the filtered load, and it's about 3.6 moles a day which is about, as I always say, a box of Arm & Hammer baking soda is coming through all our glomeruli every day. So let's take these three examples. Let's say in the first patient, the GFR decrease is responsible for the maintenance phase. So we elevate the bicarbonate and we decrease the GFR such that the filtered load and therefore the reabsorption amount by the nephron is normal, right? So normally, I didn't talk about the reabsorption. The filtered load is 3,600, but since there's no bicarbonate in the urine, this is how much bicarbonate the nephrons are absorbing also. So the filtered load matches the reabsorptive amount. That's another key concept to remember in a normal kidney. So let's take this patient with a metabolic alkalosis, but let's cut the GFR from 144 to 103 such that when we multiply these two things, the filtered load is still 3,600. Well, here we've now got a patient maintaining a metabolic alkalosis, but there's nothing that the nephron has to do. The tubule is still reabsorbing 3,600. Filtered load is, sorry, 3,600. The filtered load is still 3,600. The entire maintenance is due to the fact that the GFR has gone down by the same factor that the bicarbonate went up. So here we have maintenance purely due to an abnormal GFR. The nephron doesn't have to do anything else as far as its transport processes. So that's an extreme, but definitely possible. And as I'll show, Marty Kogan showed that that's actually occurring during vomiting. Now, what about a situation where you have increased reabsorption responsible for the maintenance phase? Well, let's increase the bicarbonate, but keep the GFR the same, such as a patient with Barter's or Gittleman syndrome, right? They have a normal GFR, but their bicarbonate's elevated. Well, there, the maintenance cannot be due to a lowered GFR. The filtered load here, if anything, and the reabsorption are much higher. Multiply 35 times 144, you get a filtered load of 5,000. So the reabsorption must be 5,000. So here we have the maintenance not due to anything other than that the nephron is absorbing more bicarbonate than it normally would be. Its absorption has gone up by 5,000 minus 3,600, which is around 1,400 more milliequivalents per day the kidney is reclaiming. And that's why the blood bicarbonate is staying at 35. So another extreme. Here, the GFR is decreased by whatever the bicarb went up, so it's solely due to the lowered filtered load, and the tubule's doing nothing. And here, the GFR is staying the same. Filtered load then goes up, and the reabsorption amount has to go up commensurately. Or you could have both. I mean, you could pick numbers in the middle. The GFR decrease with increased absorption are both responsible. So take the bicarb of 35 and pick a GFR in the middle between these two extremes, let's say 124. So here we have a filtered load and reabsorption of 4,340. So here the nephron transport rate has gone up from 3,600. It's gone up by about 700 milliequivalents a day. But the rest of the maintenance is due to the GFR. So this gives you an idea. Obviously, you can have anything in between. So whenever you have a patient with metabolic alkalosis and you have the maintenance phase, you should always think of whether it's due to the GFR, the tubule absorbing more, or both. And the extremes are a volume depletion with vomiting, let's say, where you have a chloride sensitive. The chloride sensitive metabolic alkaloses tend to be more GFR, whereas the chloride non-responsive or insensitive, like Gittleman syndrome, Barter's syndrome, these kind of things are due to the tubule absorbing more, independent of what the GFR is, because the GFR is normal. They don't have CKD. They don't have pre-renal failure from volume depletion. So maintenance phase, now that you know, you have to think about it, break it up into whether the GFR is doing it or the tubule is absorbing more. So Marty Kogan looked at this a number of years ago in the 80s. He did two studies, both in humans. He created a metabolic alkalosis by essentially NG suction. Sodium chloride was not normal in the diet. So NG suction, like vomiting. And the control bicarbonates were all around 25, and he got them up to about 32 by NG suction. He also measured, though, the GFR. and he found that the GFR did decrease, as you might expect, just from volume depletion, pre-renal failure. We can ignore the net acid excretion column for the sake of what we're talking about now. And what he concluded from this was that the GFR was responsible for 40%, and the increased tubule reabsorption was responsible for 60%. And he then went on to do a subsequent study where he showed that the reduced GFR can alone by itself account for the maintenance phase in humans. And what he needed to do that was just to give sodium or potassium bicarbonate with the NG suction. So when he created the metabolic alkalosis with NG suction, and he also gave sodium or potassium bicarbonate, in that situation, it was solely the drop in the GFR. There was no increased tubule reabsorption that accounted for the maintenance phase. So here is just, I think it's the only study in humans looking at GFR versus tubular reabsorption, trying to break it up into one or the other. So we'll stop there for today. We'll talk more about the role of chloride, because that's not the end of the story. There's a whole series of papers that came up from a group that we'll talk about next week that looked at chloride in much, much more detail. Then we'll talk about pendrin, the chloride bicarbonate exchanger, and the collecting duct that is responsible for the chloride effect that we now know occurs. It is a collecting duct effect due to this chloride bicarbonate exchange process. We'll talk about the rest of the tubule machinery that's involved, and then we'll go back into clinical cases. We'll go right from the clinical case and try to pierce right down into the tubule and see what's going on in each of those types of patients, chloride responsive, chloride non-responsive, as to what of these factors is exactly going on. Okay, so I think I'll stop there for today. Does anybody have any questions at all? Okay, thanks everybody. We'll see you next week.